Hello everybody, welcome to EAUTV from EAU25 from Madrid. We have here esteemed faculty with Fabian Falkenbach from the Martini Clinic in Germany, Markus Graefen also from the Martini Clinic in Germany, and Laurence Klotz from Toronto in Canada. All well-known experts in prostate cancer, and we are addressing prostate cancer indeed during this episode here on EAU2V. And I would like to get started. Laurie, please tell us about the results you were presenting here on Optimum. Could you make us a short summary of what the results are?
Of course. So this was a prospective randomized trial, international trial, 8 countries, 20 sites, that sought to develop higher level evidence on the diagnostic performance of high-resolution micro-ultrasound for imaging prior to biopsy compared to MRI. So there's about 80 studies in the literature of performance of micro-ultrasound. It's fairly new technology, 29 megahertz. Resolution is 3 times higher, so you can see alterations in ductal anatomy. The basic underlying principle is similar to MRI. So the study involved 802 patients who were randomized into 3 arms. Micro-ultrasound alone with targeted and systematic biopsy, MRI with conventional ultrasound, fusion targeted biopsy, and the combination of MRI and high resolution micro-ultrasound, and blinding to the MRI when the ultrasound was done, and unblinding, and again target biopsy if there's a different target. So to make a long story short, the study accrued successfully, and the analysis, it was a non-inferiority design. Investigator-initiated trial, by the way, but sponsorship from the exact imaging company. So the study essentially demonstrated non-inferiority with very high p-value. And in fact, there was about a 4% higher diagnostic rate of clinically significant cancer, grade group 2 or higher, in the micro-ultrasound targeted biopsies compared to the MRI and conventional fusion targeted. So again, non-inferiority was clearly demonstrated. We're not necessarily claiming superiority, but certainly non-inferiority. And whether we looked at intention to treat per protocol, grade group 2 or higher, grade group 3 or higher, targeted only, targeted plus systematic, the results were very consistent. So, the appeal of micro-ultrasound is it's a lot less expensive. It's one stop for imaging and biopsy. It avoids some of the errors of fusion targeting. Second visit, there's no gadolinium. It really is kind of an appealing alternative to MRI. They're complementary. You get cases where the lesion's visible only on MRI, and also cases where it's visible only on ultrasound. So I don't think it's going to replace MRI, but it certainly is a very appealing alternative, particularly I think in regions where access to MRI, getting rapid access to MRI in these patients with elevated PSA is a challenge. It's certainly a challenge in Canada, and it's a challenge in many, many parts of the world.
I really like the design that you have set up with the balancing the risk. 1 out of 6 patients actually will only receive the micro-ultrasound arm or approach in isolation. All the others do have a safety net of MRI. So it really allowed you to get a good balance and to see what each of the techniques is able to do. Do you think now, with the more or less plethora of data we have out there, using MRI as a diagnostic tool, level 1 evidence, repeated level 1 evidence to show that it is really effective, is this one trial head-to-head against MRI enough to say this is a true alternative to MRI, or do we need, as we had with MRI, repeated studies using the same technique, prove it once, 3, 4 times again?
So, to me, there's 2 parts to your question. The whole issue of doing imaging before biopsy, that's a lot of those prospective randomized trials address that issue. That's a done deal now. The standard of care is imaging before biopsy. So now the question is, what is the best way to image before biopsy? And look, this study I think has shown pretty conclusively that you can image with this alternative strategy as well. So, MRI is not going away, but I think that, I think this is sufficient to really support using micro-ultrasound as an alternative. Part of the appeal too, frankly, is this is urology driven. So it kind of puts imaging back into the hands, if they want, back into the hands of urologists. You know, there are pitfalls. Now, if you go that route, the urologist is now the imaging diagnostician. So this is something you can't do lightly. You have to make a commitment, develop expertise. It's not hard to develop expertise. We have data on that for people who are used to doing ultrasound. But you know, it's a kind of another alternative for urologists in that diagnostic pathway.
That's the point I want to address. We are still struggling with the quality, the expertise that comes with MRI. Do you see the same issues with this micro-ultrasound, or is it easier to learn, easier to apply? What is the process, the learning curve to get a urologist become a diagnostic specialist for prostate cancer?
Yeah, so I think my own personal opinion on this is that it's considerably easier to develop expertise with this than with MRI. You know, MRI, it's multi-parametric, so you've got to develop that expertise of integrating the 3 different kinds of images. Takes quite a bit of experience. This, we have data that after somewhere around 20 to 50 cases, one can become proficient at identifying the lesion. There's excellent learning resources that the company's provided, you know, online tools where you can kind of jump the learning curve and get expertise pretty quickly. So I think it's very feasible that urologists will develop expertise with this if they embrace it.
So the system or the approach is sensitized to the need of training, education.
Very much so, yeah.
The infrastructure is there to provide that knowledge and that training, which should make the application of this technique feasible outside of these experts.
Absolutely, and these courses are freely available online, provided by the company.
That is for sure great news, I think, for urology, and it is for sure a game changer. Coming to the other game changer session we had this morning that was reporting on the RANK trial, which is the German trial looking at the effect of local treatment surgery in patients that are oligometastatic. Why don't you give us a short summary of the results of this study?
Thank you for the invitation. So we randomized 132 patients to radical prostatectomy with or to basal systemic therapy with or without radical prostatectomy. It was also a multi-center, international IIT, non-industry sponsored, and we looked at cancer-specific mortality as a primary endpoint. After 5 years, we've seen that patients who received additional radical prostatectomy to best systemic treatment had a benefit in cancer-specific mortality of around about 10%. And so this is basically showing that also radical prostatectomy can be done nicely as a local treatment alternative to radiotherapy in this setting, which this is an established treatment algorithm after Stampede.
And where fits that into the other local alternative we have, treatment alternative we have, which is radiotherapy? Markus?
Yeah, I think so. To understand this study, we had to put it in the perspective that we had already lots of data from Stampede and the Horrocks trial showing that there's a benefit, even though it's discussed at this moment in time with more intensive medication. But we thought as urologists we have a good local treatment with radical prostatectomy, and in expert hands it has a low morbidity. So why not applying this in the same scenario with oligometastatic disease? And that was the purpose of that study. As Fabian has said, it was a patient-sponsored thing. It was not industry-sponsored. It was patients' donation that we used for this. And we could show a survival benefit. So we certainly have to put this in perspective with all the new medication. We are planning to keep on going, trying to establish that. But I think we can, with this study, we have now, the first time, randomized data on a survival benefit in this patient. So I think it's a very strong message that comes from this study. Despite the fact that we had to close it earlier. Why did we close it? Because we saw in 2018 the survival benefit given by Stampede. And we were discussing back and forth amongst us whether we should keep on going with the trial, but then we finally closed it because we had kind of ethical concerns, not offering local treatment, which was shown for radiotherapy, so we closed the trial. Despite that fact, we followed 132 patients and reached the final endpoint, despite the fact that the numbers are not what we expected at the beginning.
We have another trial looking at the effect of local treatment in metastatic prostate cancer patients, hormone sensitive, low volume, the PEACE-1 trial, that actually did not show a survival benefit in the patients, but showed a better local control and less local complications linked to the patient that were treated with radiotherapy. Where did you put RAMP into the context with PEACE? And did you also check for the better local control you might have in the situation? Is it something that also is shown with surgery relative to what we had in PEACE-1?
I think you can discuss long times about how you interpret, and we had a session here on the meeting, whether that adds something to the value of the whole concept of treatment, local treatment, yes or not, and even might be in high volume. That has been discussed by companies. You know that. I think what we can say as urologists that we have a very effective treatment, and certainly local complications. We have to look at urinary incontinence, certainly, but otherwise, in these patients who were operated did not have any local complication except of things like lymphoceles, which is easy to, at the end of the day, to handle, or like anastomotic leakage. That was the other major complication. That means 10 days more of catheter. But otherwise, these patients, none of them needed something like a TUR, none of them needed a double J stent, none of them needed an nephrostomy. So I think that gives a point that we have a very, very effective treatment with radical prostatectomy, and now we have to keep on going to create more evidence.
And if I remember well, patients were selected based on conventional imaging. There were up to 5 metastases, that's correct?
Maybe you answer that?
Yes, so we used both conventional and molecular imaging. 1/3 of patients did have molecular imaging. So it's, I think this is an advantage of the study, that we also encouraged and accepted PSMA PET imaging. So this is the case here. Also, at the beginning, we only had 1 to 3 metastases, and then we changed it due to a protocol amendment to up to 5. And just like one point to the local complications, we also will publish later on about the patient-reported outcome measures, but the preliminary data is showing that although there might a little bit more of incontinence in the radical prostatectomy arm, by nature makes sense, they will see in the domains a benefit in obstructive and irritative symptoms. And if you put this into perspective, that in some like retrospective studies, there's up to 1/3 of patients who have obstructive uropathy in the last year of life for metastatic prostate cancer in general. I think later on we're going to see also their signal that this is maybe a valid treatment alternative.
And where would you put this study then in the context with the Chinese study that did the same, was published 2 or 3 years ago and showing the same effect? Comparing ADT plus surgery versus ADT alone, something we would not do anymore nowadays, but that's the problem we have with prostate cancer. The standard of care does change so quickly that once we read out our studies, we end up with a standard of care at that time point that is no more up to date.
Yeah, I must say that I realized that this Chinese study was not, I think, not recognized as it should be, I think. There were some issues with the statistics. You can argue about that, but at the end of the day, it was a randomized trial. So they put the patients into a randomized trial, which I think is a big thing. And it showed a survival benefit. And you said it's only hormonal therapy, but about 27% of these patients received some additional treatment. So I think if you put it all together, the quality of data is not comparable, and we must admit that, to radiation therapy community, no doubt about it. But we have this Chinese trial, we have the RAMP trial, which is an international trial, we have tons of retrospective data pointing all in the same direction. So I think we can now accept that radical prostatectomy is or should be accepted as a local treatment option. We should give the patient this option and then make an informed decision with that.
And especially, I think it is a relevance. We will more and more be in a situation where conventional imaging is no more done for staging. We will have molecular imaging, PET PSMA, where we might have this situation, M0 on conventional imaging, M1 on PET PSMA. And there's nice to have this information that the local treatment in a potentially metastatic patient is of help. And it is no harm to stick to the rules we had beforehand that local treatment should be done in these patients.
Absolutely, and I think this is a very important point because we, as Fabian said, at the beginning it was 1 to 3 metastases, but then with molecular imaging we realized that more and more patients are coming, so we kind of adapted the protocol to more metastases seen on molecular imaging, raising it up to 5. That was the reason why we did this amendment. But now we have a study. We have a study that includes these patients and showed a survival benefit, and that is something unique too.
Very good. We had another game changer today that was Translate, your case study looking at the efficacy of transperineal biopsy versus transrectal biopsy under local anesthesia, endpoint being the diagnosis of significant prostate cancer, isograde group 2 and higher. Laurie, what is your feeling about this study? Can you quickly summarize and tell us what this teaches you and where that changes the management of our patients nowadays?
Yeah, so I thought it was a nice study. I mean, well done study, meticulous, large cohort. And the results, the primary endpoint was diagnosis rate, which I found kind of questionable because, at least to my mind, there's been a number of systematic reviews and meta-analyses that show essentially the diagnosis rate isn't much different. Mm-hmm. The issue is sepsis, bleeding. I should say I switched over to transperineal, I don't know, 3-4 years ago, and I definitely think in retrospect that was the right move. But what the study showed was a 5% improvement in the primary endpoint of clinically significant cancer diagnosis. And it showed a non-significant trend to sepsis. I'm a little surprised it didn't reach significance because actually there was quite a difference in the rate of infection, but p-value greater than 0.05. So I think if you embrace the data in that study, you would say, well, there's a higher diagnosis rate, which is why we're doing the biopsy. And maybe there's a benefit in terms of urosepsis. And so it supports switching to transperineal. The discussant, Declan Murphy, kind of punted a little bit and said, well, really there's a role for both because it's not that much of a difference. I think in many places that the problem of sepsis after transrectal biopsy remains an issue. It's remained an issue in my practice despite trying everything in terms of antibiotics and washout and matching the antibiotic to the culture and so on. And so I think the study demonstrates a benefit to transperineal, and I really support I think, increasingly widespread tendency to move away from transrectal.
I think a very important point in the 4 studies that were done in this scenario comparing transperineal with transrectal, they systematically, as recommended, used antibiotics in the transrectal arm, where there were no antibiotics in the transperineal arm.
Right.
And if we look at the antibiotic stewardship, which I think should be a major thing to concentrate on in the years to come, it is so obvious that you have a possibility to do the biopsy with maybe even indeed better diagnostic performance without antibiotics.
Absolutely.
There's no discussion what way you should choose and what way you should do. If we still burn antibiotics, and we personally in our center use now for the cases we still do transrectal biopsy, we have some operators doing this third generation cephalosporin, which is very effective, but it is not where you would use such a precious antibiotic in a systematic fashion if you can avoid it. That's why we 3/4 of our biopsy switch to transperineal biopsy. So I think that is the way to go.
I couldn't agree more. And I believe that the whole antibiotic stewardship role for us is important. And, a couple other things about that. Cipro is widely used as the antibiotic prophylaxis. Cipro is a scary drug. And the European Medical Council, I believe, came out against it. There's some data, it's not widely known that it can have psychiatric effects, that it can induce suicide in people who showed no evidence of suicidal thoughts before. So, those are kind of subtle advantages of moving away from an antibiotic-dependent procedure that I think are really important.
Quinolones are banned in Europe actually for this purpose, for prophylactic purpose. Not necessarily because it's not effective, but the side effects are too important to justify it. That's why we switched to the third generation cephalosporin, but I don't think that's the way to go.
They're still widely used in North America, as far as I know.
And if you would be able to have the same detection rate, the same complication rate, but not using antibiotics, that's already for me the argument to go transperineal. And now we have an additional strong argument to go transperineal because we will even be more able to diagnose prostate cancer. Anything you would like to add?
Maybe
some other-
just want to mirror or what you just said. We abandoned transrectal biopsies about 3 years ago, exactly for the reasons you said. And I think it's and if we now have a study that shows even a higher rate of significant cancer, that's another argument. But that was not the reason why we switched.
Something you would like to add to Rand?
Terrific study.
Thank you very much for the contribution
you.
for the discussion. Very lively, and see you later around here in the meeting.
Thank you. Thanks, Jochen.